Good morning, good afternoon, and good evening. It is a pleasure to have you all here today for our first spotlight session in which current users of extra radiators showcase a recent work of theirs and share some tips and tricks around their methodology to benefit the wider community. I am Zsófia Tallos, North American Sales Director at Extral, and we are joined here today by Professor Rebecca Oberley-Deegan from the University of Nebraska, who will present her very exciting work on using SARRP to measure orthotopic prostate cancers. Professor Oberley-Deegan's laboratory studies how free radicals produced during radiation induce fibrosis of normal tissue injury while simultaneously promote tumor growth after radiation exposure. Her focus is to reduce side effects associated with cancer therapy. Thank you so much, Rebecca, for offering to present and sharing your time and knowledge. Before we start, a little housekeeping. If you want to ask a question, there is a question window in the Go To toolbar. You can type your questions there and we will discuss them at the end. This session is being recorded and you will receive a link to the recording soon after the meeting. And with that said, over to you, Rebecca.
Thank you very much. So my name is Rebecca Oberley-Deegan, and I'm going to be talking about how to use the SARRP CT to measure orthotopic prostate cancer tumors. So the most common way to image tumors in real time is to use a luciferase expressing cell system. And what this entails is taking luciferase gene and transfecting that into a cancer cell. And then this acts as a reporter to basically glow when this luciferase gene is activated by a drug called luciferin. And so what you do is you transfect your cancer cells with this, and then you implant that into the animal, and then you inject the substrate, and usually this is luciferin, and then you acquire an image to actually be able to see that tumor in real time. And of course, since you don't have to kill the animal to do this, you can do multiple injections of this luciferin over time and really get an idea of how that tumor is progressing. But there are some problems with this imaging modality. The first is that it's hard to detect tumors that are not subcutaneous. And so, and we're looking at orthotopic model of prostate cancer where we're actually injecting those tumor cells directly into the prostate. So it's, in the center of the animal. It's not right underneath the skin, and so it's the luciferase is harder to actually leave that signal to leave through all those different tissues, so you can detect it. So that's one issue. Another issue is that luciferin sometimes doesn't distribute evenly throughout the animal. And so you can imagine if luciferin gets to one tissue type more than another, you might have a lot of variability on what you're able to actually observe when you're trying to look at your tumor cells. Another problem you can actually run into is that the cells can be really difficult to transfect with the luciferase construct. We've had this issue with some of our mouse cells, and so you can't use a human promoter. You have to actually use a mouse promoter, and these constructs are really expensive and time-consuming sometimes. And so for all those reasons, using the luciferase expressing system is not the best. And I'm going to show you here, this is data that we got from our laboratory where we orthotopically implanted prostate tumors in each of these animals. And we then, and these cells have that luciferase expressing cassette in them, so that when we inject with luciferin, we should be able to then see this through that IVUS imager. And you can see in panel A, this is what these animals look like when you image them. And the blue area is going to be an area where there's not as much signal, and the red is going to be where you have a lot higher signal. And then in C, this is the actual tumors that we took out of the animals right after we imaged them. And so you can see that this animal in the middle, we were never able to actually detect a tumor in there when we injected with luciferin. However, we could actually palpate that, and when we pulled the tumor out, it was quite large. And so you can see that this is not always the most accurate way to measure these tumors. And in general, what we see is that it underestimates the size of the largest tumors. And we think this is probably due to the fact that luciferin is not being evenly distributed throughout that tumor. So we decided that we wanted to see if there's a better way of doing this, because we were obviously getting really frustrated. 1 out of 5 animals that had a tumor, we weren't able to actually visualize. So we hypothesized that using a CT imaging system might be a little more accurate way to quantify the orthotopic growth of these prostate cancer cells. So what we did for our first step in this process was we wanted to understand the anatomical features of the mouse prostate. And so what we did is we injected a contrast dye. In this case, we use iodine, and we injected it directly in the prostate of a deceased mouse, so that A, we could get really good image because the mouse isn't moving, and then B, we could be able to take multiple images to really get an idea of where this prostate sits in relation to other landmarks in the animal. And so the purple arrow here is directly at the prostate. The yellow arrow is at the bladder. And so you can just appreciate kind of where these anatomical features are. This circle here is the anus. And then we have some leg bones that we can use as markers, as well as the spine. And so we use this to be able to, so that we could routinely be able to identify where the prostate is, because the prostate is not a really, good organ to be seen using CT. And so there, you have to use a lot of other landmarks to be able to really say that, yes, this is the prostate. So we did this experiment, and we felt fairly confident that we knew what we were looking at when we were imaging these animals. And so we then did another set of experiments where we just took normal mice. We didn't actually put a tumor in them, and we just wanted to see what a normal prostate looks like. And so these were live animals, and we color coded them based on the anatomical structure. So right here, the crosshair is on the bladder. The bladder is usually pretty easy to identify in these tissues, and so that's what we always look for first. And then based on where the bladder is, then we can determine where the prostate is. And so the yellow is the bladder, the red is the prostate. So you can see you can't see the prostate very well on this coronal section, but you can see it well on the sagittal and the transverse sections. So here is the red. The green are these seminal vesicles, which are only present in the mouse. And so that's shown in green. And then the blue is the colon. And so you can see the colon and all of the sections as well in relation to the bladder. And then here is a way to actually look at this without the coloring. So here again is the bladder, and you can see it on both the transverse and the sagittal sections. And then you can also see that this is the prostate that's right underneath the bladder. And this is really small. Generally, in a black 6 mouse that's about 10 weeks of age, they're about 4 centimeters cubed, or sorry, 4 millimeters cubed. And then a nude animal, they're a little bit larger. It's about 6 millimeters per cube. So I encourage you to, whatever strain of animal you're looking at, to really get a good baseline for what is a normal prostate size of the animal, because obviously age is going to affect that as well. As the animal's age, that prostate's going to get larger as well. So that's what we did. And then we moved on to try to look at a tumor. So here's the steps to measure the prostate via CT. So this animal we're basically trying to enhance that contrast to be able to see the anatomical features of that prostate. And so we do this by changing the white and black contrast scale here on the top panel in the MaryPlan program. And so we make it so that we can really see these anatomical features well. And so what you see here, again, this is the bladder. Some of these air bubbles, this is indicative of the GI tract. And then if you look up here, this would be the liver. And then here's the lung, and here's the heart. And then obviously you can see some of the bone structure. You have the rib cage here, you have the spine here as well. And again, here's the prostate, and this is a normal prostate. Again, this is not a tumor. And then this is the bladder. So you want to have this so that you're able to really see these landmarks well, and you can adjust this, through these different dials for black and white contrast. Okay, so that's the first thing that we do once we get our image in MiriPlan. Then what we do is we actually measure the length and width of the tumor in millimeters. So here's an example of a tumor that's been implanted in the animal, and this is probably about a month after implantation. And you can see that at these different viewpoints, you can see this tumor in different ways. And so the transverse angle, we definitely can see the width of that tumor nicely. We can also measure the height sometimes with this tumor as well. Other times it's easier to see it with some of these other viewpoints. So a lot of times we will use this sagittal viewpoint to actually measure the length of the tumor as well. And so it just kind of depends. Sometimes these tumors are not spherical and they can have kind of a weird shape to them. And so sometimes what we do is we take multiple measurements and average them together to kind of get an idea of what the actual size of that tumor is. And so basically how to do this is we use this list of reference points. And so we are able to enter the name. So let's say we want to measure the uppermost part of this tumor. So we would click on this point here, and we would label this as up or down or height or however it is that you want to measure it. So you know this is the top of the tumor. So and then you click on another using the same pointer, point again, and click on another point, which is at the bottom of that tumor. And you can say that this is the down point. And then you can then highlight those two points, and it will give you the distance between those two markers. And this is in millimeters. And so this will tell us this is 4.8 millimeters in height on that tumor. And then we do the same thing for the length of the tumor. So we would put something like left, right, is usually what we do. So we would put a marker here for left, put a marker here for right, then we would highlight those, and then it would give us what that distance is. And so from that information, we can then calculate the tumor volume using the formula that we use when we measure with calipers, and that is the length divided by 2 times the width squared. And that will give us the volume of that tumor. And again, that will be in millimeters cubed after we do those calculations. And so this is how we actually are able to measure that size of that tumor using the MiriPlan system. So this is the data that we got when we compared our using the CT measurements to the actual size of the tumor when we pulled it out and measured it with the calipers. So the first thing that you can appreciate is that we're getting nice growth curves over time. So we're seeing that in every case, we're seeing that the tumor seems to be increasing as time progresses. There are some animals where we don't see much tumor growth, and that happens, but this looks pretty normal. And when we, at the end, so at this 45-day time point, we did one final measurement using the CT, and then we took the tumors out and then we measured them with the calipers. And you can see for about every tumor that we've got, so this is each animal, so you can see that we're getting really nice, consistent measurements between both the CT and what we were able to observe with the calipers. And there's only one animal where we had some discrepancy, and again, that was fairly small. And so if we actually calculate the tumor volume between using CT and using the calipers ex vivo, we saw absolutely no difference in that tumor volume between all of the animals that we measured. So this is telling us that the CT measurement is fairly accurate. So that now we compared this with IVUS. So in this same experiment, we then imaged animals with IVUS, and then we imaged them with CT. And again, you can appreciate that with CT, we're getting good growth curves. With IVUS, we're getting some of these really strange growth curves where we have the tumor's high and then it's low. Or we have a tumor that like just took off, really drastically. And then if we look at this per animal, you can see again, we've got with IVUS, which is in blue, we're getting kind of a strange growth curve where tumors don't shrink, they keep growing. So you can see that this one, in the IVUS, it looked like it shrunk, whereas with CT, it was growing like it was supposed to. In another animal, again, you have an increase, you have a decrease, you have an increase, whereas with the CT, we're able to see this nice progression of growth. And then animal 3, we see the same thing again, where you have a really high amount of a tumor burden, and then at the last measurement, it's substantially lower. And again, it's not because that tumor has shrunk, it's because there's something going on with that imaging system where it's not able to detect the larger tumors. And again, CT, we're getting a nice growth curve. So then when we compare the IVUS to the actual CT numbers versus what we pulled out of the animals, again, you can appreciate that the CT is fairly accurate. So we're getting 81 millimeters. This was 87. We detected 804 millimeters. When we pulled it out, it was 751, but this is also a strangely shaped tumor, so that's really hard to even quantify with calipers. When it's more spheroid shape, you can see that we get nice correlation, so 424 to 435. This animal was 435 and this was 611. We probably did not capture this last little bit on here. And then we had 164 and versus 188. And again, we were able to see this tumor that the IVUS imager was not able to see. So we think that the CT modality is a much more accurate way to measure than the luciferase system. And to kind of look at this a little more closely is we actually try to correlate the different imaging modalities with each other. And so on the y-axis, we have the amount of total photons that are being released with the IVUS imager, which is indicative of tumor size, versus the actual tumor volume that we were able to measure on CT. And you can see there's not very much correlation here. If we do the same experiment where we are on the y-axis is what was measured ex vivo with the calipers versus what was measured with our CT, you can see that we got a nice R-square value, and it was statistically significant with a p-value of 0.0001. If we then use the IVUS measurements shown here on the x-axis versus the ex vivo measurements with a caliper, again, you see that there's very little correlation. That R-square value is very low and the p-value is very low. So we feel that CT is more accurate for measuring these orthotopic prostate tumors as compared to the luciferase system. This data has been published in an article in PLOS One back in 2022. So if you want to see more details, please go there for a reference. And I'd also would like to thank the people that helped with this particular project. I'd like to acknowledge Dr. Elizabeth Kosmachek and Dr. Arpita Chatterjee for their help on this project, as well as Molly Myers. They were the ones that did the majority of the work on this project, and I would be happy to take any questions. So thank you.
Thank you, Rebecca. That was excellent. We already have a couple of questions that have come in during the talk, so we can start with those. As for the audience, please feel free to type any additional questions you may have in the chat, and we will get to them. So the first question is, how could you tell the difference between normal prostate tissue and tumor tissue on the CT image?
You really can't, just by size. So like I said, if you have a prostate that is about 4 millimeters cubed in the black 6 animal, that's likely just a prostate, and there's not a tumor that's been developed yet. If you we'll track these animals over time. Next time you measure it, it might be 6 millimeters cubed. Then you think, okay, there's likely a tumor that's growing here. And if that remains at 4 millimeters, then likely that tumor in that animal didn't take, and you're measuring a normal prostate. So you really need to know in each strain of animal that you're working with, what is the normal size of a prostate, so that you can determine what the normal size is. And then when you see that it gets larger, then you can assume that that tumor is growing in that animal.
Thank you. So the next question is there a contrast agent known to be used in living mouse for prostate?
Not that I'm aware of. There may be some type of dye that you could inject like IV into the animal. I'm not aware of that. I don't know what's used clinically to look at the prostate specifically. So the easy way to do it is like what we did, where you just inject the dye directly in the target tissue that you are looking at, and you know that you want it to, so that you're not also highlighting other types of tissues in that vicinity as well, so you know what that what that area looks like under the CT. The other thing that you can do, which we didn't do, but is you can put in fiducial markers. So you can put in when you're injecting the tumor into the prostate, you could put little like pieces of metal in that injection site, so that you know exactly where you injected, and you can then be able to use that as kind of a landmark to look at if you're still not certain with your CT image. So like pancreatic cancer, like pancreas is really difficult to see on CT. So if you have a tissue that really does not show up very well on the CT, you could put that on there, and that would also help you to start to look at. We have done pancreatic tumors. When they get large enough, you can see them visually on the CT imager, but when they're small, you can't really disseminate that from the actual pancreas, because it's really hard to even see the pancreas under the normal conditions on a CT. So it depends on what organ you're looking at, but that's another way to kind of get around it. But I'm not aware of any dye that's specific for prostate that you can use for contrast agent in the mice.
Thank you. Now we have two questions that are quite similar. So how much time does it take to do each mouse? And which method took more time for measuring tumor size, BLI or CT?
So for the time for imaging the animals, we could only do one animal at a time, and it takes about maybe 3 minutes in total to get the image and then to do the measurements. So you can get pretty quick doing it. So it usually, if we have like, I don't know, maybe 20 animals, we can usually get that done in an hour for imaging using the CT imager. The compared to the IVIS machine, you can do 5 animals at a time, but you also have to wait 15 minutes after you inject. So really, it takes about an hour to be able to measure about 20 animals using the IVIS imager as well. So there really isn't that much more time. It may be a little more time intensive to do the CT analysis, but it's not that much more.
Okay. Then relating to this, on our SARRP, we often take CT image of 2 mice at the same time. Would this technique be feasible on multi-mice CT images to facilitate throughput?
We have not tried that. My guess is that you might be able to do 2 if they're like really separated from each other, but I think it makes it more difficult to be able to get the contrast set up so that you have a good picture for each mouse. Because I mean, I guess you could maybe take that same image and then redo the contrast so that you can see it better in the second animal, and then do your measurements that way. So you may be able to speed it up a little bit that way. We have not done that. We've only used a single bed, and we've just done the CT imaging that way. So that's something that you could try and see if it would work. I don't know.
Thank you. There are definitely reproducibility issues with BLI. However, it is also measuring a fundamentally different aspect of the tumor, viable cells that are translating the reporter, as opposed to the overall tumor volume, which may include areas of stoma, necrosis, or non-viable cells. Did you correlate imaging results with tumor histology?
We did not correlate with histology. There definitely was not a huge necrotic center in these tumors. Like, we've done histology on them in the past. I just didn't do it with these particular experiments. But there's not a huge necrotic center on these things. There isn't a lot of fibrosis in these tumors either. So that I can tell you just histologically, but I did not correlate that with our imaging or with the IVUS. So I can't comment, specifically with the experiments that we did, but I can tell you that we've done histology on these tumors in the past, and that's what we have observed. So there could be some of that going on, but I don't think that accounts for everything that we're seeing in these discrepancies.
Next one. How do you measure the sizes of the tumors ex vivo? Is it also by only measuring lengths and widths?
Yes. So we just measured length and width. The longest measurement lengthwise and widthwise is how we use to measure those tumors with the calipers.
Okay. What other tissue types do you think this method may be applied on, and what would you recommend to sites wanting to give it a try?
As I mentioned before, we've done this with the pancreatic cancer, and we couldn't see it when the tumors were small, but we could see them when they got larger. So we wouldn't be able to track them when they're really small, but we could see them when they get bigger. So I think, if you have the ability to either see the tissue well, so like bladder, if you're looking at bladder cancer, I think this would work great because you can see the bladder really easily in these animals, and you can see that tumor. Again, like lung, I think this would work really well. You can really see a good contrast with the lung tissue. And so I think that would be a good modality. Some of the GI might also be something that you could potentially monitor. We have not tried to do that yet, and we do have some GI cancer models. We have not tried doing that yet. We're looking more at metastasis with that, which the IVUS does a better job than we can do with the CT. The CT will probably only be good for looking at primary tumors because we can't get to that small of a scale to see the small number of cells that are disseminating throughout the body. So, but I think that you could use this technique in a lot of different tumor sites. And then if like in the pancreas, where you really don't have good CT visualization of that organ, you can use those fiducial markers, and that can help you as well. So I think there's ways to get around it. And it just depends. And so a lot of our animal models are also genetic models where you don't have a way, this is the tumor is just developing on its own. You don't have a way to really monitor that, using the IVUS instrument, because those cells are not expressing luciferase in general. And so I think this would also be a good way to monitor that over time, in a type of a GEM model where you've got a mouse model that these mice spontaneously develop these tumors over time. You could probably see that with this imaging modality as well.
And then, do you know the radiation dose associated with the optimized CT imaging used here?
Oh, it's really small. I can't remember off the top of my head. I want to say it's like 0.1 millicurie or something like that. It's little. It's whatever. We're just using the normal CT imaging modality in the SARRP. So whatever that radiation doses, which is teeny tiny compared to what we give to the tumors when we're irradiating. We see absolutely no effect. Like those tumors are not shrinking when we image these cells. So that's we use this imager also, or this instrument also, to irradiate our tumors as well and look at growth over time, and we do not see any inhibition of growth when we're doing the CT imaging. So I don't think that's a concern.
And then I think we have time for one more question. Can you detect lymph nodes or metastasis?
I don't think that you can detect either one very reliably. Maybe if you have a really enlarged lymph node, you might be able to see that, but I think that's going to be really difficult to discern on the CT imager. So, and metastases, I don't think you'll be able to, unless if the met's large, like, if you were to open the animal up and you could actually see it, I think you could see that on CT, but you're not going to see like micromets like you can on the IBIS.
Thank you. So I think that given that we have run out of time, that concludes our first Spotlight Journal Club webinar. Thank you so much, Rebecca, again for the fantastic presentation, and to everyone on the call for joining us today.